You gotta start TikTok.
You started?
No.
Oh, you fooled me.
I just
I
did
thought
the
that's what you were out there
screen
Okay.
Hello, everybody. Welcome to Fertility Fact or Fiction. And we're going to give everybody a minute to log on. It usually takes people like a minute to jump on.
All right, everybody's here. Not everybody's here, but you're everywhere now.
I'm everywhere.
You're everywhere.
They're not everywhere.
They're not everywhere yet.
No, we're still working on it.
You know, I was looking for you on TikTok and I kept typing fertility fact and fiction, and like, I was just showing up other things, but I wasn't showing you. I'm just like, why can't I find Dr. Victory? And then lo and behold, I have to type in Dr. Victory.
Oh, really? There you go. We got Nick B. Hi, Nick B.
Oh, you're zoomed down. What happened?
I don't know. You're joined.
Of course.
Well, that's really great. Seeing myself like right up close.
Yeah. Now, there it is.
All right.
That's the doc that we love.
Welcome, everybody. This is Fertility Fact or Fiction. If you have experienced any bleeding in pregnancy, this show is for you because this is super cool what we're going to talk about tonight. Heretofore, otherwise unreleased information, and very cool, very neat, something that I didn't even know about. I had heard about. There's like a rumor, and I thought I'm going to look this up, and it's pretty surprising what this data shows. And then there's some newer data that's even more impressive, and then there's a suggestion of something else that's even more impressive. So the question is, do we have a new therapeutic for women that are bleeding in pregnancy that might turn things around? So we're going to talk about all that tonight and go over things. And if you guys have ever experienced some bleeding in pregnancy or what's called a subchorionic hemorrhage, or your friends have, please make sure they know that we are here and on and ready to discuss this, because this is a bit of a game changer. And I love the game changers. I love the ones where we can do something that's significant and make a difference. And the beauty of this one is it's all natural too. So it's very, very cool. Hopefully you guys have had a great week. I have been busy writing my, not writing exactly, I'm doing my board exam for the US. So they send you a ton of articles and you have to go through the articles, and then they ask you these questions, and then you can't answer the questions unless you've really in-depth read the article. Mm-hmm. So you got to go through the articles and then answer the questions. It's actually a really good learning experience. Again, I mean, I've read most of them, so I kind of quiz myself by answering without actually, reading the article, and then I go back and I look how I did.
I'm surprised you still need to read after we do
the show.
Yeah.
It's got stuff in there. Like I one of the articles was all on day 7 embryos. So actually, it's good fodder for what we can present here. Absolutely. Yeah, because there's a whole thing. But the day 7 article one wasn't good. It was like 5 different doctors arguing about whether or not they should use it. It was poorly done. But anyways, yeah, it's a cool experience. So you have to get a minimum of, what is it, 88% or 90% or something like that, or else they make you write another exam.
Oh, wow.
Yeah. So far,
it's a pretty good high threshold.
I'm at 100% so far.
And go on to 100%.
Yeah, no, 100% is good. So I've done 5 papers.
That was my bare minimum when I was in grade school. I was forbidden from anything less.
Yeah, I know. My dad was the same way. I got 97 in my overall in grade 13 calculus, and my dad said, "What happened to the other 30%?"
That's it. That is the way it is.
Do you need that guy? I think you do. That will
somebody needs that.
Somebody needs that. Yeah,
absolutely.
All right, so we can screen share. You want to screen share?
Are you sharing? Oh, yeah.
I'm sharing is caring. Okay, so for those of you on TikTok, thank you for joining us. I can see you all there. Christina M. Fraser 450 Mason. So I can't display what I'm talking about, but I will read you off the numbers and stuff so that you know, and we'll be explaining it. And the numbers aren't that important in this one. It's more the outcome. So the title of this is Resolution of Subchorionic Hematoma and Symptoms of Threatened Miscarriage Using Vaginal Alpha-Lipoic Acid or Progesterone, Clinical Evidences. So let's just talk about what this is. Subchorionic hemorrhage is when the pregnancy has a bleed between the sac that the pregnancy is in and the uterus itself. So it's between the chorion and the uterus. And when you bleed there, for whatever reason, it can trickle out, and so you present with spotting or bleeding. It's often painful, and it is essentially a threatened miscarriage because some of those people will go on to miscarry. Depending on which study you read, as high as about 25%. So in those circumstances, when you have that kind of bleeding there, we traditionally don't have a lot to offer people. They've tried progesterone, we stop aspirin or heparin if you're on aspirin or heparin. We've tried bed rest, we've tried not bed rest. Lots of things have been tried. No one's ever actually shown that one thing is better than another. However, there was a suggestion that patients on alpha lipoic acid actually did better. So these guys, which are in Italy, in Ferrara, Italy, decided that they would run an actual randomized controlled trial looking to see what happened if you gave patients vaginal ALA. Now, I have to admit, I would probably have to get ALA compounded if I was going to use it vaginally. We just give it to our patients orally when they have either PCOS or endo, because there's lots of research showing that ALA for PCOS and endo patients is beneficial. What is ALA? It's a very potent antioxidant medication that is completely natural. It's a supplement. You don't need a prescription. You can buy it over the counter. And so the question is, can we actually help women who have a bleed to essentially settle the bleed down, including the symptoms of pain and cramping and so on, and the bleeding, reduce the size of the bleed, which is important for maintaining the integrity and safety and security of the pregnancy. And then in theory, although there's no data for this yet, maybe reduce the miscarriage rate, which is huge, right? Like if we can reduce miscarriages with something natural, massive game changer, right? So when I saw this, I was like, this is cool. Let's take a look at this. So we're going to go into the study, and I'm going to tell you what these guys did. So they recruited 76 people, and they randomized them into a ALA or a progesterone group or a control group, okay? So the controls got nothing, and then the randomized group got either vaginal progesterone or they got to have the vaginal ALA. So 27 in each group, and then 22 in the control group. So in the ALA group, only 3 people miscarried, which left them with 24, and double that number miscarried in the progesterone group, which is interesting, right? I mean, that's a lot. So that left them with 21 in that group. And then 5 people miscarried in the control group, which left them with 17 people for analysis. So the first thing you got to notice is there's less people miscarrying in the ALA group. Could be a thing. In terms of the data, nothing was significantly different between the groups. So the average age, like around the 30-year-old mark, gestational age, most of them were actually fairly far into the pregnancy. So the bleeds are like 8 to 9 weeks, not just 6-weekers, but like 8 to 9 week pregnancies. About 50% in the ALA group had never been pregnant before, 41% in the progesterone group, 41% in the control group. None of these patients had previously been pregnant. Out of the group, some of them had had miscarriages, kind of random. And then a fair number of these had had at least one previous miscarriage, right? So about, somewhere around a quarter to a fifth of these patients had previously miscarried. And some even multiple times, 2 or more. About half of them presented with vaginal bleeding, a little more in the control group. And then the size of the hemorrhage was considered medium in about 90% plus in the groups. About 11%, 7 to 11% were considered large in the group, okay? So then they went through and they analyzed it, and I'm going to blow this up, so hopefully you got a good view there. You got a good view of that. Mm-hmm. So the important thing to note here, and let me see if I can get this to, oops, that's not what I wanted. Yes. Okay, so the blue line shown here is the ALA group. And what you can see is that when they looked at the two different time references, which were I think 20 and 60 days in this study, in terms of how quickly the hematoma resorbed, there was a higher proportion of resorption at the first time interval, way higher, in the group that took ALA. How high? Like 80% of the hematoma had resorbed, over 80% or 85%, by the first time interval versus about 48, 49% in the group that was on progesterone or the group that took nothing. And also note, along here, if you look there, both the green and the red line are overlapping, which means the control group and the progesterone group didn't actually get any difference in outcome, which means progesterone by itself is kind of useless. You're not getting any benefit to doing that. So not particularly useful, but if you're taking ALA, you get a much more rapid resolution of the hematoma, so that at the first time interval, almost double the amount of resorption of the hematoma has occurred. And this stuff has no side effects. Like, there's no downside to this. It's not even expensive. It's easy to use. Yes, we might have to get it compounded vaginally, but you can also take it orally very easily, and it might actually help things out. When they looked at this from the standpoint of, when they looked at this from the standpoint of what happened in the groups as far as percent improvement of the subchorionic hematoma, the ALA group, hugely statistically significant. Again, big increase. You're looking at like 83, 84% versus about 48, 49% in the progesterone group, and no difference with the control group. So hugely significant finding that you get this big resorption when you use the ALA. When they looked at other symptoms, they looked at pelvic pain and vaginal bleeding. So in the first column there, you're going to see, and I need to blow this up so everyone can see it. In the first column, you're going to see ALA, progesterone, and the control group. And for those of you on TikTok, just to make you aware, basically almost everybody had some degree of pelvic pain, and about half of the patients, or slightly more, 2/3, had some degree of bleeding. When they went to time 1, in the ALA group, no one had any more bleeding and no one complained of pain. So already by the time you hit time 1, if you have not miscarried, there was no bleeding and no pain. Now, they excluded the people that were bleeding, that were having miscarriages. So those ones don't count. But for the ones that continued on, there's no pain and no bleeding. Whereas in the progesterone group, 14% still had pain, but thankfully no one was bleeding. And 12% in the control group still had pain, and they also had bleeding. By the time you get to the second time, there is 0% pain in anyone and 0% bleeding. But then they looked at their miscarriage stats again, and you can see that there's 3 in the ALA group versus 6 in the progesterone and 5 with the control. So overall, this does very much look like ALA has immunomodulatory and antioxidant effects that can actually tell your immune system to help clean up a hematoma. We've never seen this before. I literally don't know of any substance anywhere that will allow you to achieve these kinds of results. And yes, this is a very small study, but it's actually a well-done study, and it's phenomenal in the results because you're showing faster resorption, less symptomatology, and maybe less miscarriage, which is huge, massive game changer. So then what they did was they came out with a newer study just recently, and in this study, I think it's part of the same group, but at a different location in Italy. The first one was in Ferrara, and this one's in Modena. Modena is where Ferraris are made, for those of you that know that I'm a car nut. So this is very interesting, because what these guys did was they took hyaluronic acid, which is embryo glue. They took alpha lipoic acid, they added in magnesium, vitamin B6, and vitamin D, and they did a pilot study to see what would happen. So there's a bunch of different dosages and stuff, and I won't bore you with all of that. But suffice it to say, they took this witch's brew of a bunch of stuff and they put it together. So they took 56 pregnant women with threatened miscarriage. They put 25 in the control group and they took 31 in the treatment group. There were 2 dropouts from the control, 1 dropout from the treatment group, and they ended up with 23 that completed the control side, 30 that completed the treatment side. So then they went through their results, and they actually have some cool pictures for you to see here too. So no statistically significant differences in age, weight, gestational age, parity, previous C-sections, previous miscarriage. It was all kind of the same thing. So the groups are very comparable, which was great. Okay, so there was an improvement in both groups over time compared to time 0, and I'll show you that in a second. And you can see it here where there's little bleeds in these pictures where the arrows are, but over time, when you go from the top to the bottom, you can see that they are improving slowly and getting better. So there was definitely improvements in both groups. But when you actually look at the data at time 1, the treatment group, which is the green bar there, you can see, is statistically significantly faster in terms of its size of the subchorionic hemorrhage, that it shrank compared to the control group. And by the time you get to T2, it's even more significant, with almost a negligible size left to the hemorrhage compared to the patients that were in the control group and they weren't getting anything. So a huge, huge, huge difference there. These guys also looked at things like pain, bleeding, contractions. So at time 0, about 2/3 had bleeding in the control group, 50% in the treatment group. All of them had pain, all of them had some cramping and uterine contractions. At time 1, in the control group, you still had 43% that had bleeding, but you only had 3% bleeding when they took all the supplements all together. And they had 61% complaining of pain versus only 30% in the treatment group. 91% complained of contractions versus 40%. And the importance with contractions, which is huge, is again, when the uterus is contracting, it's trying to expel the contents of the uterus, which means you've got a way better chance of not miscarrying, in theory, if you actually are controlling the contractions. By the time they got to time 2, nobody in the treatment group was having any bleeding. Nobody was having contractions. There was some pain, but it was down to just 3% versus 8.7% still bleeding, 30% having pain, and 52% still experiencing contractions. So these are huge, huge differences in these groups, which is phenomenal. Oops. So end of the day, we can stop sharing that. At the end of the day, the important thing here is that with a very, very simple natural substance or a bunch of natural substances, you actually can significantly improve your bleeding in pregnancy and maybe stave off any risk of miscarriage. How important do I think this is? I'm actually going to make everybody take ALA from now on, just for all our cases. Like, this is enormous, right? And we have lots of patients on aspirin. So this may be the best way ever to get the benefits of aspirin without the risks of the bleeding. All our patients that need to be anticoagulated for a variety of reasons, huge potential to reduce the chances. So this is going to be a great study. We're going to try one here, but I'm going to get people on this and start seeing how this works. Because if we can actually demonstrate that we are reducing miscarriage rates, massive game changer, massive game changer. So make sure that if you have the opportunity, you run down to your health food store, pick up some ALA, obviously check with your physician first, but this is natural stuff, over the counter, no known negative side effects, and potentially massively beneficial. And I think that's it. On to questions, I guess.
And you got a bunch.
I've got them, but we usually have a bunch.
There were some questions related to Is vaginal ALA versus oral the same effect?
We don't know. We don't know. I don't know the answer to that. I wish I did, but I don't know. We can see in this study, so these guys did, let's see where their supplements were. Yeah, so these guys did oral ALA in this study at 100 milligrams. We usually give 600. And in the other study, they did vaginal. So based on the fact that the results are very similar, I would assume that you get similar results, regardless of oral or vaginal.
Another question related to this study is, in this study, how did they account for the possibility of chromosome abnormalities for the miscarriage?
They did. And remember, very few of the patients actually ended up miscarrying. So they had a huge benefit there.
So alpha-halpoic acid as a suppository?
You can have it compounded as a suppository. I'm not aware that it's actually available that way, but I might take the data from this study and actually make a victory miscarriage pill and start marketing that, because that seems awesome. Yeah. So I'm going to talk to pharmacy and see if they can do that. Kinga, if you're watching, I got a job for you. Yeah. But this stuff is huge. Like, we've never had anything that can reduce bleeding.
First time I heard about it.
They actually think it can, and this one's relevant to you, they actually think that this can reduce preeclampsia.
Oh, really? Wow.
Big deal.
Because of all that, right?
Yeah.
I can see that.
Big deal. Yeah. Yeah. It's very, very cool. This is huge. It's a big deal.
What is the ALA dose in pregnancy? Is it 600? And how far into pregnancy do you take it? And can it be oral?
Yeah, we use oral. We use 600, and we tell our patients not to stop. So yeah, that's what we do.
Just trying to find anything related to this study. Bear with me. Scouring the comment section.
I got a TikToker from Kelsey Marie.
They're asking what amount of ALA did they use in the study?
100 in the second study, oral. The compounded vaginal one, I want to say 10 milligrams, but let me pull it up for you again. It was 10 milligrams of ALA. DAV vaginal capsules from Low.Lee Pharma in Rome, Italy. 1 capsule per day before sleeping. Yeah, so 10 milligrams vaginal, 100 oral. We actually use way higher doses than that, but yeah. I'm so stoked by this. Like, I think this is going to be huge. Huge.
Oh, it's a huge thing.
The other thing is, if it's this good at preventing bleeding and stuff, can it increase implantation? Which may be part of why our endo protocol works so well, because we put all our patients on ALA. So maybe that's a big part of it. Could be.
Could be.
Yeah.
Ready for fertility questions?
I'm ready for fertility questions.
Okay. Thoughts on immunology testing after 3 failed transfers with no implantation?
Mandatory. Yeah,
I concur with that.
Yeah. Mandatory. I mean, I talked to a lady today who had 4 failed transfers at one of the biggest clinics in Toronto with donor egg embryos. And the question was, why is it not working? And I said, have you done immune testing? And she said, no. And she'd actually seen a reproductive immunologist, and they didn't do testing either, which kind of shocked me. So yeah, you need to do testing. Microbiome and immune, both.
Is AMH2 low? I'm 35, TTC, HO laparomyomectomy, and hyperprolactinemia.
Hyperprolactinemia.
Anemia.
Hyperprolactinemia.
Okay. Prolactin 30 to 31 and 40% viable sperm count.
I don't know what the units are for your 2. If it's 2 nanograms per mil, no, that's not low. If it's 2 picomoles per liter, that would be considered very low, unfortunately. Yeah.
At what point should someone who experienced preterm loss 19 weeks try FET again?
Oh, well, not until you figure out why you lost your pregnancy at 19 weeks. That, to me, always spells infection as the first thing to rule out. So we strongly advocate for checking the microbiome, but it's totally up to you as to what you do. And obviously you have to speak to your physician, but I would not go forward until you've figured out why you had the loss. First of all, I'm very, very sorry for the loss. That's tragic and very hard to recover from. So, I mean, if you're doing additional testing, I would do that first. If you are not interested in doing additional testing, I'd probably give your body a month or two and then you're ready to go.
What does 6 months of high IgM mean while also not being able to conceive?
You've got something that is chronically trying to activate your immediate response portion of your immune system. Something's bothering your immune system. You need to see a reproductive immunologist or even a rheumatologist or an allergist or someone like that.
Best immunosuppressant during pregnancy.
Best immunosuppressant? I mean, there's lots, right? Sirolimus, tacrolimus, steroids, Plaquenil, IVIG, intralipids, sub-QIG. I don't know that there's a best. It's each one for different indications. Probably the strongest overall in terms of managing immune problems would be IVIG, but it doesn't cover everything and it's insanely expensive and it's not always indicated. So you need to talk to us or a reproductive immunologist before you decide that.
Hi, Dr. V and Dr. T. I'm a patient of yours getting induced at 36 weeks due to my history of third trimester loss.
Yes.
If you are unable to place a Foley, what is your next method of induction?
Prostaglandins, as long as you've never had a cesarean section before. So we would go to prostaglandins. Yeah. Prepidil or Servidil or one of those. I spun a baby around today. I'm really good at doing that.
Yeah, you've mentioned that before.
I
remember that.
So it was breech.
Mm-hmm.
We gave her an epidural. You push up on the kid's butt, and it just like it literally took me less than a minute. Just went. Everybody's like, "Okay, are we doing a section?" I'm like, "No, I spun the baby around." So, yeah.
Wow. So let me just understand this correctly.
Yeah.
So baby's in breech.
Baby's head's up here.
Baby's head's up here.
Butt's down there.
Butt's down there. You have two options.
Yeah.
You can do this move. You flip it. I can't
Yeah.
forget.
Wax on, wax off.
Yeah. You can do that, right?
Yeah.
Or you do a cesarean section.
Or you can try and deliver the baby vaginally, which is not
That's
safe.
not safe. Yeah. That's dangerous. I can see that. I've seen enough TV shows to know that.
It used to be done all the time, but now it's considered unsafe.
Oh, really?
Yeah.
So
there was
before it
a
was
trial
okay.
back in 2000 from Mary Hannah, a midwife in Toronto, international randomized controlled trial. 700% increase in fetal morbidity and mortality.
700%.
When they did breech. So they stopped it globally. Like everybody stopped doing it. So you can either turn the baby, which is challenging. Typically success rate's about 25%, or you can just do a C-section, pull the kid out breech. So this mom said, turn the baby for me, so I spun it. It was super cool. I love doing it. It's like really, it's one of those like ultimately satisfying things.
It's a super skill from the sounds of it. Like you saved this woman
A C-section.
A C-section.
Yeah.
You saved her months of bed rest.
Well, no, it doesn't take that long, but
A month for sure. A month of, at least a month of pain.
a week.
No way.
A week. Yeah. Women are tough. They
I know
recover,
they're tough.
They recover quick.
They recover.
But it was
There's
awesome.
pain.
Yeah. It was awesome though. It was very cool. Yeah.
You are very cool.
I'm very happy with that. Yeah. Oh wait, can I just answer this one quickly?
Sure.
Updates on availability of sub-QIG for those of you that have been wondering. I finally have the phone number of the guy in charge. We're trying to arrange a Zoom meeting. He wants to establish 2 committees, which I don't have time for, so I need to talk to him and see what he says, but there is hope. There is hope. I'm working on it. It's going to take a little bit of time, but there is hope. Yeah, I'm hoping within the next couple of months.
Thoughts on rebiopsying abnormals and complex abnormals?
Oh, well, complex, we're actually going to start doing. So we are going to offer the complex or what they call chaotic embryos. as being rebiopsied, because otherwise you're not going to use them, and a very small percentage of them, depending on what study you read, maybe as high as 10% could actually be normal. So we are offering to rebiopsy those embryos. Yeah, there is one study that showed that when they were chaotic, they rebiopsied 30%, and 30% of that 30% actually came back normal, which is terrifying. Did you hear that they're suing all the PGT companies? Did I tell you that?
No.
I didn't tell you that.
Didn't say this.
3 of the biggest PGT companies are getting sued for misleading people.
Oh, wow.
Yeah, because they claimed apparently that it reduces miscarriage and it's this, that, and the other thing, and better chances, which nobody has ever shown, although we all know that it's true. But there's not actually any concrete, tangible data to show that. The only thing that's out there is data to show it reduces miscarriages. And there's also data that shows that you get pregnant faster. But there's no data that shows that, you have a higher live birth rate chance. Because the only 2 studies that ever studied it, they weren't done well. Yeah, so it's going to be exciting to see what happens with that. There's going to be some pain for people.
Some pain.
Yeah.
What could be the reason for an unusually high attrition from day 3 to day 5 blast?
Bad sperm would be number 1. So if you had lots of embryos on day 3 and they didn't make it to blast, it's most likely going to be a sperm problem. It could be an egg problem, but more of the time it's going to be a sperm problem.
What supplements are safe to resume for PCOS while weaning from breastfeeding to head into another FET cycle?
ALA, coenzyme Q10. Probably be okay with resveratrol, vitamin D, melatonin, your prenatals, folic acid, all of that stuff would be fine. Your fish oils. I might stay away from inositol and NAC, but the rest of them should be okay.
When your patients get pregnant, are you seeing them until birth, or do you prefer them to switch to an OB after the first trimester?
So if they're local here, most of our patients stay with us and I take care of them and end up managing them for their pregnancy.
Hey docs. Plural, just in case it wasn't enunciated properly.
He gave me a smoldering view. It's like, yeah.
What role does estrogen play in a medicated cycle, and how do I know that my body doesn't need the extra estrogen in a modified natural cycle?
The only role it plays is to thicken the lining, but the counterpoint to that is that it increases inflammation, increases risks of IUGR, increases preeclampsia risk, it increases risks of virtually everything, and I think it decreases success. So it shouldn't be used. There's lots of studies now showing that natural or letrozole are better. The conference I was just at in Spain, it was a broad European conference, people from all over the place. And even they said very clearly that it's time to give up the hormone replacement therapy cycles and move to doing natural cycles. And then I went and spoke to one of the main guys that presented, and I said, why aren't you guys talking about letrozole? He said, basically, one step at a time. It's too early for Europe to accept that. They're still stuck using hormone replacement therapy cycles. And Tarek and I were watching some internal data from one of the Canadian clinics a little while ago during a presentation that was being given just privately. And the success rates at that particular clinic, which are very good, and it's a very, very large, well-known clinic, not even close to what we're getting. So I think moving to the letrozole protocol is the way to go.
Yeah.
For sure.
For sure. Good evening from Jamaica.
Jamaica. Everything ID. I was in Jamaica. I love Jamaica. It's beautiful. So nice.
With only a couple of embryos. Suspected, move the cursor, endo.
Yeah.
2 previous miscarriages.
Yeah.
Would you recommend endo surgery Fertility, or anything else prior to a transfer?
Well, if you have endo, I would definitely recommend an endo protocol, which may include a surgery, or should include surgery, in my opinion. Yeah, I mean, if you only have 2 embryos, I would do fertility for sure. Why not optimize everything? Fertility is awesome. I mean, it doesn't have to be fertility. I don't want to support fertility above any other company. But getting an assessment of your microbiome that is accurate, and getting an assessment of your immune system and immunoreactivity to your partner is critical. So I'm feeding Tarek chocolate, and he's about to put it in his mouth when he realized I just finished my statement.
Yeah,
so
you abruptly stopped is what I would call that. That's an abrupt stop.
Yeah.
How can I come to you for fertility testing and or treatments?
Oh, just call the office. Yeah, we treat people all the time. We now have like a fertility package for managing people's fertility issues. So if you're in Ontario and you have OHIP, then you don't need to worry. It's all covered by OHIP as far as my consultation. You have to pay for your fertility. But if you're outside of Ontario, we have a package now for managing your fertility stuff. So just call the clinic, go on the website, reach out to info@drvictory.com, drvictory.com. Go on our website and book a consult. Any of those will work.
Did the study include women who were pregnant before, or was it just the first pregnancy?
In the second one, I don't remember. In the first one, they were all first pregnancies.
What are the ways to prevent premature rupture of membrane?
Premature rupture of membranes is almost always caused by infection. Not 100%, but almost always. So if you know that there is a adverse or suboptimal microbiome before you get pregnant and you correct it, it will cut down your chances of delivering preterm. We use antibiotics for some of our patients the whole way through the pregnancy. I've found a lot of success with that. No evidence for it, but I can tell you anecdotally that I think it works. Progesterone is likely beneficial. Not doing anything too exertional, no heavy lifting, straining, has never been shown to be beneficial, but at the same time, telling someone to strain when they're at risk for rupture doesn't make intuitive sense to me. So there are a variety of things you can do, but number one is eliminating the risk of infection. And the best way to do that is test the microbiome and correct it before you get the patient pregnant.
Are there any symptoms with chronic endometritis?
Nope, not a one. Literally nothing. There are no symptoms with chronic endometritis. You don't know that you have it. Yeah, and I have a video that I got to give you. Don't finish tonight without showing you that video on endometritis that we are coming out with, which talks about all the different aspects of it and what is best for therapy, because there's a lot of nonsense out there that's going on for chronic endometritis, and we need to stop the nonsense. Fight the power.
Fight the power.
Fight
That's
the power.
right.
Yeah. That's good chocolate, eh?
I took a bite. I'm like, whoa! I took too big of a bite. This is too good to just eat.
That
like
is good chocolate. Yeah.
What are your thoughts on doing the Alice test before transfer after one failed FET with a complex mosaic?
Oh, wow. Yeah. So I personally am not a big fan of Alice. I'll give you a good example. I looked at one of their reports yesterday and shared this with a patient that had called in. So the patient had no Lactobacillus crispatus, did have Lactobacillus gasseri, borderline amount, and then had absolutely no other bacteria in there. That's not possible, right? Like, if there's no crispatus in there, there's got to be something else. So I don't trust their analysis because it just doesn't make sense to me. Maybe it's totally valid. I'm not critiquing the company in any way, but I just don't trust the results because they don't make sense to me. So we don't use them. If you're going to do it, either find a different company or we use Fertility. I've been very happy with them. It's really easy to understand. It's grouped according to bacterial type. It's great.
I cherry picked this question just because it seems it's a goodie.
Okay.
Is it true? So I figured it's like a fact or fiction thing.
Mm-hmm.
Is it true that women with PCOS
Yes.
start menopause later than women without PCOS?
Probably because their ovaries are very strong.
Oh, okay. I expected a little bit more. Okay.
Yeah, well, they have sky-high AMH and lots of follicles. So it takes a while for that to dwindle down. So your menopause is delayed.
Gotcha. Makes sense.
Yeah.
What are the chances of having a successful pregnancy with a unicornate uterus?
Unicornate uterus usually doesn't stop you from getting pregnant. It is associated with a higher risk of having miscarriages, although that's not really 100% clear. And it's also definitely a higher risk of having a breech baby, and we don't try and term them when you're unicornate. There isn't enough space. But otherwise, like I've operated on loads of women who had unicornate uterus, and we did C-sections, and they did fine.
Hello, Dr. Rahi.
Oh, all right. First name basis.
Yeah, there we go.
Yeah.
It's your best friend.
Yeah.
What are your thoughts on testosterone priming for 2 weeks instead of 3 weeks?
Testosterone priming has been shown in 2 separate randomized controlled trials to be useless. So with very rare exception, we don't use it. Yeah, it's useless. It doesn't help.
So 2 weeks or 3 weeks, go with 0.
Go with 0. Yeah, it doesn't help
0.
you. Yeah.
Oh, funny question. My wife comes up to me today
Okay.
and she's like, so when did you become an expert? Well, this is going to sound a little bit off. Let me rephrase how I'm going with this. She's like, so you're talking about orgasms now.
Oh, whoa. It went there.
I said, what? She goes, yeah, I saw it online. You're talking about orgasms. I said, no, I don't. She's like, yeah, you absolutely talked about orgasms. I heard it.
Yeah. You're dead now.
So I'm thinking to myself, what did I say when? And then luckily, I reviewed the content that we publish here.
Yeah.
And there was one question about having an FET transfer.
Yeah. Should they or should they not orgasm?
Was it should they not orgasm?
Yeah.
I was just reading a question. I'm not explaining orgasm or anything. This is separate content.
That's Fertility After Dark.
That's Fertility After Dark.
Actually, I have a presentation on that one too. I got video content for you off the wazoo.
I'm right here.
I know.
So yeah,
It's all the time, man.
that was only time in my life I've been questioned about
talking about orgasm.
talking about orgasms. So
We gotta get Merv to watch the show. It would be so fun.
no. I think I'd come home and he wouldn't see me again. That's it. What happens in this show is sometimes really
It's Vegas. Yeah.
it's sometimes a little bit wild in here.
Margot says, "I remember Dr. T. You're guilty."
Yeah. I said the word, but my wife was going on a different tangent. She was thinking I was like doing something else over here. I don't know what she was doing online.
Scroll back a couple. I think there was some good.
Boy, there's a bunch. Yeah. There's a bunch here.
I can fire through a bunch of them.
Okay. Dr. V, your thoughts on Plaquenil? Do you ever prescribe before an FET?
All the time. For all of our patients with high NK cells, we use Plaquenil.
Thoughts on suppression with birth control versus Lupron for undiagnosed endo?
Birth control has absolutely no evidence that it is beneficial prior to an FET for undiagnosed endo, and more importantly, there is evidence that people that take birth control prior to an FET increase their risk of miscarriage. So we try not to do that. There are some instances where we have to, but generally speaking, we try not to do that.
The OB told me I have a narrow pelvis and never do VBAC. How can I confirm I have a narrow pelvis?
So a million years ago,
I love a million years ago.
Yeah, you'll
this is really good science.
Like
here.
60, 70 years ago.
Okay, here we go.
They used to X-ray women's pelvises with the freaking baby in there.
Oh wow!
X-ray with the baby in
no
there.
lead.
No lead.
No lead.
To see if the baby's head was bigger than the pelvic bones.
Oh.
And if it was, they would tell them you need a C-section. Just like forget it, it's not going to happen. You need to have a cesarean.
Oh, okay.
And then they realized this isn't a good idea, not because they were irradiating the poor babies in there, but actually because they realized that it was useless. So even when women had pelvises that measured smaller than the baby's head, it had absolutely no correlation with the success of delivery. So then they stopped doing it, and it was actually a research study. So it doesn't matter if your pelvis is small, you just try. If it works, it works. If it doesn't work, you get a C-section.
Miracle of childbirth.
The miracle of childbirth. Because you got to remember, your pubic bones are joined in the front with a piece of cartilage and some ligaments. And at the back, more cartilage as they attach to the rest of your pelvis. So the bottom line is those bones can pull apart because the cartilage softens because your body releases something called matrix metalloproteinases, which kind of chew up the cartilage, make it soft. And so your cartilage is softer so the bones can pull apart so the baby can actually wiggle through there.
Wow.
That's how it works.
Unbelievable.
Yeah, it's cool.
That's amazing.
So you don't necessarily have to 100% measure the pelvis. Now, granted, sometimes we get these tiny little women and they're carrying 10-pound babies. Okay, it's not going to work. Plus, even if it did, God, that's what we call a vaginal cesarean section, and nobody wants that. Yeah. But if it's like a reasonable size baby and a reasonable size mummy, yeah, I mean, talk to your doctor and see if you're suitable for being a VBAC, which we now call TOLAC. It's no longer called VBAC. It is a trial of labor after cesarean section.
Take your word on that. Hi, doctors.
Yeah, I know you love that.
Yeah.
Yeah.
First, you put FET failed.
That tastes better for you than the chocolate.
Oh yeah, 100%. This is I can do so much.
You just soak that up.
I take this all in.
I know.
I go home.
Yeah.
You know, get destroyed by my wife. But in the back of my mind, it doesn't matter what she says. I'm a doctor.
You're a doctor.
I'm a doctor. You know, because there's a bit of a what is it called? You know, in quote unquote Middle Eastern culture, being a doctor is basically as good as it gets.
It is. Yeah.
You know, and you're
doctor, lawyer, engineer.
Yeah,
in that order.
Doctor,
lawyer.
But doctor's number one.
It's number one.
Doctor's number one.
I know. I had to make my mom proud. That's the whole
there you go. See, I did not make my mom proud. Back to the question. First, you put FET failed to implant. All additional BW and endometrial biopsies for endometriosis normal.
Yeah.
I think endo. What is a good endo protocol? 37 unexplained infertility.
So our endo protocol is on our YouTube channel. So I have a slight modification now, but essentially we do 3 months of suppression, Lupron and letrozole. We try not to give you any estrogen if we can avoid it. We do double progesterone, vaginal and injectable at a high dose. We're aiming for a high concentration, which we titrate by measuring your levels. We use 5 different supplements: NAC, curcumin, resveratrol, ALA, and coenzyme Q10. And then we have an immune protocol, which we are now adding metformin to because of a show we did. Was that 3 weeks ago? 3 weeks ago, I think, where we showed metformin is actually beneficial for patients with endo. So we have a whole protocol. You can call us and do a consult, and we liberally share the protocol with you.
I've created some controversy on TikTok.
Oh, you have? Oh, what's going on?
I'm confused. So is he not a doctor?
Other people are responding.
Yeah,
he's not. He is a doctor of all things social media, and he has learned, in fairness to T, he has learned enough to have educated conversations about many gynecologic and fertility-related and obstetrical-related topics. But he does not technically have a medical degree yet. Yet.
Well said. Yeah. You know how they give honorary medical degrees?
Yeah.
Can't you one on me?
I could give you probably like an honorary fertility degree.
There we go.
You probably know more than some.
I'm sure I can go to some cities that we can think about.
Yeah.
And I could probably school the guy all up in there.
Yeah. Yeah.
The only thing I'm lacking is the physical experience.
Yeah, I can't give you
that.
Yeah. That's not gonna happen.
If anybody would want to volunteer, it'd be reduced by half the price. And it'd be a half the success rate But you'd be part of our
Yeah.
social media journey.
You'd be part of our social media journey. That would be hilarious. Yeah. Fertility treatment by Dr. T would be a whole other episode. We could do a show.
Yeah. Imagine. Yeah. Okay. So,
Yeah.
on a serious note, so alpha lipoic acid as a suppository.
Yeah.
That's right. Do it. How far into pregnancy can? Oh, we did that question. Sorry. Oh, hold on. Let's redo it because yeah. How far into pregnancy can you take oral ALA? I have a large SCH and will be 12 weeks tomorrow.
Just stay on it and don't come off. That would be my advice.
You're telling your watch is telling you to stand up. Somehow they were able to see it. No time to stand up.
Those are some dedicated viewers, eh?
Oh, we have the best viewers.
That's hilarious.
We have the best viewers.
Yeah, I can't stand up. The camera's right at my crotch height. That's not going to be a good look.
It's not. This is not the time nor the show for that.
That's a whole other fertility.
That's not orgasm show I was talking
That's
about.
not orgasm show. Yeah.
Hang on. ALA is a suppository?
Yeah, ALA is possible as a suppository. Yeah, I mean, you'd have to have it compounded, but yeah.
Hey docs, what role does estrogen play in a medicated cycle, and how do I know that my body doesn't need the extra estrogen in a modified natural cycle?
We just did that one.
No problem. We'll go to the next one. Hey doc, 9 weeks with bright bleeding.
Yeah.
OB/GYN said likely SH hematoma.
Yeah.
But only had an abdo ultrasound that showed heartbeat but fetus not measured.
Yeah.
Unknown heartbeat. Should I ask for a vaginal ultrasound? Also, was told high intensity exercise okay to presume. Is this your approach?
Oh, hell no. Tarek's shaking his head off camera.
See,
No,
like I
of course
said,
not. Yeah.
I am.
Dr. T.
That's right.
Dr. T is in the house.
That's right.
No, excuse me, after a bleed, you want to take it easy. Not necessarily because it's going to alter the outcome, although high intensity exercise has been associated with miscarriage. But even if it didn't alter the outcome, if you miscarry, you will forever blame yourself for doing too much. So please don't do that because you're going to regret it. So I would recommend you talk to your doctor. In our patient population, I'm going to start recommending ALA. Stop any anticoagulants. I would probably consider being on progesterone if you're not already, because we don't know if the combo of ALA and progesterone is okay compared to just progesterone alone, which appears to be useless. And I would also strongly recommend you not do anything heavy. We usually tell our patients pelvic rest. Again, I cannot advise patients on the show. You have to talk to your doctor, but we tell our patients pelvic rest. No heavy lifting, no straining, nothing in the vagina or in your pelvis 360 degrees. Don't get creative.
Creativity, not today.
Not today.
Not today.
Or tomorrow.
Yeah, that's
a few
right.
weeks.
They wanted, the individual wanted me to tell you that, noticed your watch show you stand up, that she went to see Messi.
Oh, cool.
Yeah, that's Sarah that went to see
Hi,
Messi.
Sarah. How are you?
Yeah.
That's awesome. Yeah.
At what point in a stimulation cycle and retrieval do you need to limit exercise, particularly? Okay.
Well, if it's big, you want to eliminate heavy exercise because you can tort your ovary. So if you have a lot of eggs, you don't want to be doing heavy exercise because it's going to tort. Plus, heavy exercise draws blood away from your ovaries to feed the muscles. You don't want to be doing that. So don't be doing intense exercise. I have to take this question. Can I take that question? What delivery would you recommend for women who had an open myomectomy? 100% have a cesarean section. Your risk of rupture is substantial. Depending on who did the myomectomy as well, it's extra substantial. So when you do a myomectomy, you leave this crater, and the goal is to like close the crater layer by layer by layer. But some people just go with one giant layer of stitch. Yeah, that's not a good closure. So I would always recommend you have a C-section if you took out intramural fibroids, the ones that are in the wall of the uterus.
Do you think I can advocate for taking 100 milligrams or milliliter of PIO in ethyl olate every other day instead of 50 milligrams? of regular PIO every day?
So there's a study by Shady Grove, very well done, very famous, randomized controlled trial, where they looked at using vaginal progesterone nonstop and then compared that to vaginal progesterone plus once every 3 days injection of PIO. And they showed that it had the exact same outcome. Now, I don't do that because I don't like yo-yoing, but there's no reason why you can't based on that study.
Hey doctor, my doctor said fatty liver caused my IVF failed. What do you think?
I think if you have fatty liver, there's a lot of health concerns there, and pregnancy is virtually out of the question until you get healthier and get rid of the fatty liver. So I would want to know why they were even starting with you. But I would need to know all of your details. So hard one to answer with just such limited information. Fatty liver doesn't cause IVF failure, but it is an extremely inflammatory condition with very serious health impact, especially if you get pregnant. So we would be very cautious.
Can ALA increase TSH levels?
No clue. Can it increase I've never seen that before. Let's find out.
I don't think it was a part of today's study.
It was not. Let's go. Wait, there was something. I just had it. Go ahead.
Okay.
Ask me.
Yep, no problem. Can I have a shout out?
You can have a shout out. For who?
Some guy named Harper.
Harper?
That's all there is.
Hi, Harper. Alpha lipoic acid and TSH.
Thank you for answering my question about 36-week induction methods. Are you admitted to receive prostaglandins?
No. You're just in triage for a little bit. Wait. Metformin and alpha lipoic acid ameliorate hypothyroidism and its complications in adult male rats. The next study is something called MRF. I have no idea what that is. Why is this all on rats?
I guess they didn't have a chance to try it on.
Research on the protective effects of antioxidants on metabolic syndrome induced by thyroid dysfunction. It appears that it improves your thyroid function.
There you go.
For the limited amount of data that there is. Cool.
My husband's sperm counts and motility are excellent.
Good.
But morphology is 0.
Oh, okay.
And I know morphology doesn't matter when it comes to IVF with ICSI.
Yes, it does. It hugely does.
But is there any benefit to doing a DNA fragmentation test?
Oh, God, yeah. You need a lot of testing. You need sperm binding. You probably need oxidative stress. You need sperm DNA fragmentation. Zero morphology is not going to give you the same outcome, even with ICSI, that a normal morphology will. So that is not true that it doesn't matter. It does matter. Morphology of the sperm matters with IVF, even when you're doing ICSI.
Hi, doc. I had a tubal reversal over 10 years ago.
Okay.
I never conceived after that.
Oh.
Would I still be a candidate for IVF?
That depends on your age. But if your age is reasonable and your AMH is good and your partner's sperm is good and you're healthy and all that other stuff, I do tubal reversals still all the time. I love doing tubal reversals. That was another one of the exam questions. It was comparing tubal surgery to like tubal reversal to IVF. So yeah, I mean, I still do it all the time. I have my specs over there behind you.
Someone tried to claim that we must be a pre-recorded show because we haven't answered their question.
It is not a pre-recorded show, and the proof of that is we just answered that. Yeah. What was their question? Should we give it to them?
We actually did answer their question. Their question was about the tubal reversal 10 years ago and never conceived.
There you go.
Yeah, we answered it.
Yeah.
They just gotta wait.
They gotta wait.
They gotta wait. We got
Guys are
TikTok,
patient.
we got Instagram, we got Facebook, we got YouTube.
Yeah.
There's a
Lots of people.
lot of people.
We still need LinkedIn.
Oh, LinkedIn's being friendly. How long do you recommend someone with a SCH be on progesterone and LA until it clears?
36 weeks for the
36
progesterone.
weeks?
Yeah. For the proj, we go all the way to 36 weeks. For ALA, I'd probably stop. Yeah.
How long does frozen embryos be kept, and what about rate chances of success?
Yeah, so I actually got a message from a viewer yesterday or day before yesterday, panicked about a study that showed that the success rate drops. So there are studies that say that the success rate drops, and there are many that show that it doesn't. So currently, theoretically, they think we can keep embryos frozen for about 300 years. I mean, I wouldn't wait that long, obviously, but short periods of time, years, even a decade, not a problem. The oldest one I'm aware of was 26 years later, and the embryos still worked.
Oh, really?
Yeah.
26 years later.
And that was like dinosaur technology. Yeah. Is this like a go on forever show?
No, 9 o'clock. That's it.
Oh, are we stopping?
Well, but you are the doctor. I am just.
Yeah, no, I'm good.
Yeah,
No,
I'm
that's
okay.
what we gotta do. Okay, last quick question. What to eat to improve egg quality? Eat healthy, take lots of vitamins, lots of supplements. Don't eat fatty stuff, don't eat sugary stuff. How's that? Is that good?
That's good.
And Iggy just joined. Iggy,
Welcome, Iggy.
I like that. And Casey and Max. Hi, guys. We're actually signing off now. So listen, great show. Thank you for joining. Spread the word. Make sure you tell everybody that ALA may be the thing for them. And look for lots of exciting new videos because we have some cool content coming out. We're going to talk about sex around the time of implantation. We're going to talk about endometriosis. We got all sorts of cool stuff coming up for you guys. And stay in touch. And if you want an IVF or a fertility journey that's just simply better, contact info@drvictory.com, and we'll be in touch soon. We're also going to be bringing a host of people on the show from now on for interviews. So we look forward to having you on. And next week, I think Dr. Ray Hall will be back with us as well. Not sure what the topic is, but we'll figure it out. Have a great night, guys. See you again next week on Fertility Factor.